Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today I'd like to introduce our guest, Dr. Corey Rice, who's a DO from Texas. Thank you for joining us today, Corey.
Thanks, Linda, for having me. Excited to be here.
Good. Also, I'd like to say congratulations on being our latest LDN advisory board member. So we're very privileged to have you join the team. So welcome.
Thank you.
For those people that don't know you yet, could you tell us about yourself, where you've been, what you've done, what your aims are?
Yeah, happy to. And just as before I get into that, I really do appreciate the opportunity to serve you and your organization in any way that I can. I've been a silent and now less silent supporter of what you are about and what you have built over the last 20 plus years. I have learned a lot from your website, and I've applied that to patient care now for a number of years. I've learned a lot from some of the collaborators that I hope to collaborate with that are currently serving on your board. And so I will add as much value as I can based on the clinical lens I look through and what I treat. So first and foremost, it's certainly my honor. I appreciate you saying it's your honor, but it's a reciprocal relationship. It's my honor to be a part of this, because I'm just thoroughly intrigued by a compound that has been an amazing adjunctive therapy to some of the stuff that I get into. So with that backdrop, who am I? So Linda, I didn't necessarily know that I wanted to go into healthcare years ago. My journey started out really in the world of forensic science, honestly. So I was the first graduate from Baylor University in Texas with a forensics degree. And at that time, forensics was sort of a pre-medical track. So you took all the pre-med prerequisites for that degree. But really what that led me to do is get into a side of life I didn't know existed. And that is working on the collection of bones and understanding how to identify someone from just their bones. And I actually was hired to teach at the university in forensics, and it was a very rewarding experience. I essentially learned how to put puzzles together and solve complex issues. When someone is, nefariously killed or removed or gone missing, a lot of times there's not a lot of support or voices for that person. And so I think myself and my team that was formed, our job was to give the dead a voice, essentially. And so truly that's what I did. For 3 years I taught at Baylor, and I also worked on difficult to solve forensic cases. And I like to give that backdrop so that you understand what I do now in healthcare, and I'll explain how I got here, but is truly the exact mirror of that life. I'm just looking at live humans who can laugh, who can cry, who can smile, and who can give me a story. Instead of me trying to guess what that story is, I can help them. Everyone's got a story and everyone's got a history. And so it's funny how life turns around full circle. Now I essentially do a forensic analysis on a live human. And it's the same skill set I had when I was a very young person who just finished graduating college. So quite frankly, when I left that, I had the option to get into, I got into the FBI, which in the United States is the Federal Bureau of Investigations. I turned that down and decided to go into medical school. And the reason is I was intrigued by healthcare. And so ultimately went to medical school, didn't know what I wanted to do. And now what I do, just to fast forward, I started out in internal medicine conventionally. So I was an internist here in the States and would treat chronic disease using pharmacologic therapy. That's all I knew was stack medicine upon medicine upon medicine upon medicine, and hope that the disease gets better. And I think what I learned through all my conventional training is that applying a 21st century acute care diagnostic and treatment model to chronic disease doesn't work. That's a marriage that oftentimes ends in complexity and quite frankly, divorce. And so, I went off into this world of what I would term essential or root cause medicine. Some people would call it functional medicine. Some would call it integrative medicine, holistic medicine. I don't really like the labels. I just treat people as I myself would want to be treated. So now I do have I own and operate two full-time functional medicine clinics in the Dallas area in Texas. And it is beyond a blessing to do what I do, because Linda, I mean it when I say with as much sincerity as my heart can tell you, what I've created and the team that I've assembled has created is truly a hobby for me. I don't look at this as a job. I can't imagine the word retirement. It doesn't make sense in my brain because it doesn't register. I just can't imagine not continually to increase sort of the neuroplasticity in my own brain and continue to, evolve and mature and help those synapses form in ways that help me be a better doctor. I mean, I just can't imagine not doing that, because what I know now is so much more than I knew back then. And with partnering with groups like you, I can't imagine in 10 years what I'm going to know from now. I mean, it's just that's why I love health and healthcare. So conventionally trained in internal medicine, but right now I don't do a lot of conventional internal medicine. It's all sort of root cause functional medicine. So I hope that gives you and your audience somewhat of a snapshot of what I do.
Mm-hmm. That's amazing. And forensic science really fascinates me. I've watched programs on television, where there's a dead body, and it's all these forensic files that determined how the person died and how to catch who actually killed them. I mean, that's just amazing, isn't it? And to be able to use that knowledge.
Yes, it is so amazing with what you said. Here's what I would tell you. It is an enormous blessing and it's an enormous curse. And I think why I got out of that field is because I couldn't go home, proverbially home, with the knowledge of not being able to solve what happened to this human. The people that we would find, we know that they had a story. We know they were mothers, daughters, sisters, husbands, brothers. We know that. And oftentimes you're their last hope from the grave where they were put artificially to give justice a chance on what happened to them. So there was two sides to that coin. One side was doing all you could to identify who they were so you could do your best to reunite them with their loved ones so they had a dignified burial or service or something, so it wasn't such a loose end in life. That was one. Two is to then go forward with trying to find out who or several who's put them there. And luckily we were able to solve some, but those aren't the ones that I think about. It's the ones we weren't. And those are killer. And I realized it wasn't a failure on my part. It's hard for you not to think about it that way. And you hope that through technology, through AI, through the evolution of all these capabilities in our society, that those individuals, I'm afraid they probably haven't, but I'm hopeful that they were able to find some closure, and their families were able to be reunited. And so I had to leave that field because I couldn't compartmentalize that life with having a normal life. So yes, it was a fascinating, exhilarating experience, but it also exposed me to the ugliest sides of humanity, which also requires a very unique skill set to be able to put that off to the side and focus. And so, that's probably more detail than you wanted to know, but that's essentially the idea of why I got out of that and into medicine.
So now the patients you treat, what age range do you treat them from? Cradle to grave, or do you focus on a particular age group?
Yeah, so I wouldn't say cradle to grave, although several of my patients would say they've probably been reborn by going through the experience that they go through when they go through our programs. But so it's the testing in the States is standardized, at least the adult testing is standardized on 18 and above. So um, I do not treat usually or test anyone under the age of 18. There are exceptions that are made from time to time. But the great thing is in my area, I've got pediatricians who do a lot of the same things I do in healthcare that they do it for the pediatric population. So I can send or refer them out to there. So 18 to as old as someone is alive. So 100 plus years old, it's not rare for us to have someone who is pretty seasoned. 95, 98, 105, we have those as well. So we see everything in between. So from the age percent, it's that bracket. I think the level of pathophysiology that I see, the level of pathology, it's everywhere from the healthiest of the healthy, from famous, athletes to actors and actresses to, famous coaches of some sport, all the way down to people that have less than a year to live. So I think we see everything in between because I think I've created somewhat of a reputation for I'm very aggressively focused on prevention and early detection of disease. I strongly feel that the only way you win in health is to early detect. If you wait until something degenerates to the point that the body cannot recover or recompensate, that's a problem. And so I think from my professional perspective, I like to do as much as I can on the data acquisition side so that I can early detect as much as possible so I can help put a body back together. That's essentially what it is.
Mm-hmm. Could you run through some of the testing that you do with a new patient who's got a complex condition that you're not really aware of what the root cause of that condition is?
Absolutely. So, and I'll just fill in the blank. So whether that's a 45-year-old female who last year didn't have type 1 diabetes and now she does, or it's someone who has neurologic degeneration. So ALS, Parkinson's, MS, all the way to the healthiest of the healthy and the autoimmune of the most autoimmune patient of the most autoimmune patients. Everything in between, we do a pretty deep dive on a serum analysis looking at what I like to say is I like to look at advanced metrics throughout every compartment of the body. So whether that's, inflammatory testing on the cholesterol side, I like to look at particle counts and particle sizes, but I'm not one of the docs that feels like cholesterol is the boogeyman that hides in the closet that's waiting to jump out and, give you a heart attack. I think I'm probably a little bit different than other docs. I think that there are cases in which cholesterol can be a problem, but I also think there's a lot of solutions without having to go to pharmacologic agents as a first line of therapy. So that's part of what we look at. I think every human should have their fasting insulin checked. The insulin level of a human is massively important because, at least in the United States, we are in a battle against insulin problems. This is why these weight loss injections are so popular, because really what they're doing is sensitizing the beta cells so that people are not so resistant to the insulin they're making. And really the main problem or reality with insulin is it's a growth hormone. So if you have more insulin in your body than you should have, your body grows, your belly grows, cancer grows, polyps grow, masses grow. So you have to pull the insulin out or else things will continue to grow that you don't want to have. So I think a fasting insulin is massively important. Along with the blood sugars, I do a little bit of genetic testing. I do a big autoimmune panel because again, early detection. I want to see if I'm able to detect an autoimmune problem or condition. A lot of hormone testing, a lot of thyroid testing. So that everyone gets that test. The other test I do, Linda, which I think is also super important, since COVID hit the world in 2020, whenever it was, late night 2019, mid 2020, I think a lot of patients, their health goals really center around their immune system. Well, I don't know how to completely fix a human being if I don't know objectively how their immune system is functioning. And if 70+% of our immune system is tied to the intestinal lining of our gut, therefore, I think it's almost mandatory that at some point you need to objectify your gut health. So I do a 3-day microbiome analysis in every human I see. They have to do a 3-day stool collection. I like 3-day stool collections because it eliminates recency bias based on their diet over the last 2 to 3 days, and it's a reproducible result. So if you see day 1, day 2, day 3, if you see the same things, I think that's better than just a 1-day collection that may not be as accurate. So for me, I like to do a 3-day stool analysis in every new patient, along with the serum testing. Occasionally, we will do adrenal testing. Occasionally, we'll do neurotransmitter testing, but I save that for what I call tier 2, which is later down the road. Because oftentimes, if you have a dysfunctional immune system and you have bad genetics and bad hormones and all these inflammatory things, your adrenals are messed up because of the egg the chicken laid, the chicken and the egg phenomena, right? The adrenals are just responding to what's happening in the body. So if you go after those things first, oftentimes the adrenal glands compensate, and you don't have to keep doing all these tests to just make people spend money on testing. So some testing I'll reserve for later. And then oftentimes I'll do things, I don't know if your audience is aware of this concept, but this new age testing, it's called liquid biopsies. So you essentially do a single tube of blood, and it's essentially doing a whole body biopsy of whether you currently have active cancer within your body. So it actually screens for melanoma, right? Which is a difficult one to find. It screens for pancreas cancer, brain cancer, all the different blood cancers. It's a screening test to just whole body biopsy, because cancers put off their own DNA profiles. So this blood test is looking for cancer DNA throughout the body. And so that's a nice early detective preventive screen that I like to do if people are willing to do it. So there's a bunch of things that we can do, but I think initially it's certainly the immune system analysis with the serum testing that I outlined.
Mm-hmm. And is this cancer screening that I actually haven't heard of before, is that really expensive?
Yeah. So unfortunately, when things come out and they're new, there can be a little pricey, right? So the supply demand curve, as the demand goes up, I think the price goes down. We will see. It's called the GRAIL test, GRAIL by Galleri, So it's Gallery with an I, Galleri. It's probably the number one on the market. That it's around $1,000 for that test. And what I tell people is, what is it worth to you to know if you have, because then this is the thing, Linda, it's only a diagnosis, right? So it only says you have a signal coming from the breast, or you have a signal coming from the colon. It doesn't tell you how to fix it. It just tells you it's there. Then that goes to as a patient, your treatment philosophy and what you want for your body on how you fix it. And whether that's conventional or whether that's going through something else to try to fix the cancer, that's a whole nother story. This is really just on the early detection diagnosis side. So, but I truly feel the future of healthcare is going to be a very easy experience where you come to a doctor like me, and it's not about me. There's a whole army, hopefully, of these types of docs out there, but people that if you come to someone like me, I can do a very quick test that is going to tell you within reason whether you have cancer. I can do some AI cardiovascular screening that can tell you whether you have current plaque deposition anywhere in your heart, because that's still the number one killer of you and me is heart disease. And I can do a whole body assessment of your immune system through the gut and an autoimmune screen. And I don't know if there's much better than that. I mean, because you're going to have every year or every couple of years, if you elect to do it, a whole body snapshot of what your health is doing. And to me, that's better than a whole body MRI that you've got to spend thousands of dollars on when you're not getting everything else. So, that's the idea. It can be a little pricey, but it's all depends on what you define as pricey,
Mm-hmm.
So.
But to find out what you could potentially have further down the road and intervene at that stage to stop it from developing, I mean, that's just amazing, isn't it?
Oh, I think it's the future. I think as that technology and the sensitivity and the specificity of that testing only gets better, and it's pretty good now. As it only gets better, I think that's where we're headed. People just waiting for screening colonoscopies and mammograms and, if they can afford these whole body scans and MRIs, I mean, that's one thing, but a single tube of blood, I mean, that's excellent. And I would also say there's unfortunately there's patients out there that don't want to know, and those are the kind of people I try to get to the most, because people not wanting to know, it's very scary to me, because what we're discussing here is a controllable outcome. If you can control the outcome, if you detect something early, we know if you detect cancer early enough, you can live a normal life. Waiting until something is so far down just never made a lot of sense to me. So I try to reframe people's mindsets to like, look, what do you have that you want to live for? Maybe it's your children. Maybe it's your dog. I don't know. Maybe it's your grandkids. Maybe who knows what it is, right? But though, if you want to live for that, then these are the types of tests you want to invest in so that we can make sure we keep you as healthy as possible. So I'm just lucky. I think anyone listening to this that also kind of does this type of medicine understands we're all very lucky to practice medicine in a time like now, because it's very exciting with some of the stuff that's coming out. And I just can't imagine what the future holds in the next 10 to 20 years with technology, because it's just going to be an amazingly personalized experience, I think, for the patient.
Mm-hmm. So what kind of treatments do you use? I mean, do you go out to try and fix the gut first?
Yeah.
Where do you
So,
start?
yeah. So, I would say it depends on the patient. So, generally speaking, it depends on how overwhelmed someone is, but ultimately we need to start with how they're eating, what are they eating, how does that tie into their functional markers on the gut analysis as to how we need to sort of fix that. So we normally start with repairing the gut, cooling off the bowel through the restriction of inflammatory food. And then we have to intrinsically build the immune system back up. So how we do that is through nutrient repletion, gut health, restoration, which bacteria or strains of bacteria we choose to use. If there's a pathogen, a parasite, candida, yeast, whatever, we've got to kind of suppress all of that. Then on the back end, if there's an immune system regulation problem, if they have known immune system issues or autoimmune issues, this is where sometimes I'll tie in LDN. This is sometimes where I'll tie in peptides if appropriate. So there's a few little levers that we pull with people, but it starts with gut health, addressing like restoring what we see on that profile, making sure their menu plan is one that is not too restrictive. In the initial phase, they have to go on to some form of menu plan that is, somewhat anti-inflammatory and restrictive, but the goal is to heal their gut enough to where they can kind of eat a little more liberally, right? One of my mentors long ago told me, just sticks with me forever, is when your gut is messed up, it isn't the food's fault. When you eat food and it makes you feel bad, it's not the food. So when people say gluten-free, dairy-free, and all these things, that is true. That's true if you have good gut function. If your gut's leaky and nothing's working and everything's translocating, if you eat healthy or you eat bad, it doesn't matter. Your body feels bad no matter what. You just feel bad. So you feel like you're reacting to everything because you don't know what's going on. So the key is then if you fix the gut, seal the lining of the gut so it's no longer leaky, then it matters what you eat. Then if you can remove the inflammatory foods and you can those types of things, and you can eat whole foods and you can eat veggies and lean protein and these types of things, that's when it matters. But if your gut is all messed up, it doesn't really matter if you're eating healthy or not, because what you perceive to be healthy or not, because you haven't addressed the root of the problem, which is the gut. And you and I could talk about this for 2 hours, but ultimately, if you don't fix the gut, you don't make enough serotonin either. So your neurotransmitters get compromised so that someone doesn't sleep well. They're not happy. They're depressed. They're anxious. And all of it could be the gut. And that ties in back to why I don't do all these tests on the initial encounter, because some of it is just overkill. You just need to go after the root. So yes, to answer your question, it's always address the gut first, upregulate the nutrients that you find they're low in, address their hormones always, address the hormonal imbalance, and then decide whether you want to use an immune modulator on the initial encounter like LDN or peptides, something like that.
In America, it seems as though you use IV treatments.
Mm-hmm.
Specialized clinics, I guess, in England you could, but our general health care system, we don't do IV supplements or vitamins or anything like that. I mean, how big are IV treatments in your practice?
So they're not. I don't use IVs in my practice.
You don't?
I don't. IVs are a big, they're very popular, and we've referred out for those from time to time. But it comes down to simple economics. It comes down to simple space utilization, and you have to look at what you have, the space you have, um, and the service lines you have, and decide, is running an IV clinic really what I want to do? And it isn't. I don't. That doesn't pique my interest near as much as the stuff we're involved in. So we've discussed looking at like what's called ozone therapy, or like EBO2, things like this. We bring that in before we would do IVs. IVs, Linda, I mean, there's a whole side to this where you have to like have shelf life. You gotta the clunkiness of like getting the products in, storing them, making sure they don't expire, making sure it's all done correctly. With how busy our practice is, it just doesn't make a lot of sense with the rooms we have and the space we have. So it's more of a logistics thing, I think, for us. And the fact that we know we can send them out for that if we need to.
Mm-hmm. And you touched on peptides. I mean, peptides are the buzzword, I would say, right now. Could you tell us a bit about peptides in your practice?
Yeah, sure. So, peptides is a broad term. Peptides are basically just amino acid groupings. Some of these peptides, a lot of them, they're found inside the human body. So from that standpoint, there's very little downside to peptides. Now, peptides also can have a little bit of a regulatory issue, even in the States. And, that's probably not for today's discussion, but there's a lot of reasons why that is. I would tell you that predominantly most of the peptides that we have looked at, that we have tried using, are demonstrably safe, beyond safe. I mean, have not had any patient problems. And the people that I've learned from that have taught me some of these things would say the same thing. These are very innocuous compounds. I mean, they're not conferring harm onto people. And that's obviously the oath we all took, right? So first, do no harm. So it depends. So there's brackets of these things. There's peptides that help with body composition. So, metabolism, fat loss, muscle gain. There's peptides that help with regeneration or healing of soft tissue injury. So big fan of those. So ones that, if you've got a muscle strain, muscle tear, anything like that, you can use peptide therapy around the injury site, and it helps with the facilitation of healing the area. There are peptides that help with hair loss. So as women or as men age, sometimes they lose hair. It's just part of the reality. And there's some pretty safe peptides you can use for that. Then there's a whole side of peptides that fall into the longevity, anti-aging, mitochondrial resuscitation, energy type peptides. NAD obviously being probably one of the most popular ones, I'd say. So those types of peptides, kind of, there's different ones there. There's different ones again for regeneration, for hair growth, for body composition. All the ones that fall into those categories are usually the ones we use. A little bit of the GLP-1 side of things, but honestly, not a lot. It's not as like other clinics. I mean, we use them for different reasons on the inflammation side. I think off-label, GLP-1s could be used in degenerative, like Alzheimer's, right? And some of the Parkinsonian stuff, and even multiple sclerosis, something that's like degenerative, just as an anti-inflammatory at a very, very low dose. That isn't used for weight loss, but it is a peptide that can be used, I think, for those things. But none of that has approval. It's just more of a observational based on what I see. So those are the different categories of peptides. I'm probably leaving some off that I can, like, categories I can think of, but I think most people probably know what the different peptides are that fall into those categories, and that evolves too from time to time. There's one for cognition that we'll use, sleep. I mean, it just kind of depends on what you're looking for, and if you're able to carry it in your community. That's the other part to this. Some of these things are just, I don't know why, but it gets a little bit hard to source them or get them. And the other reason, and I'll just leave it with this, is that patients, unfortunately, can get peptides now. I don't know how they do it, but online, from their gym trainer, right? The person who's teaching them how to work out and build muscle. Sometimes some of these people have like sources for this. And so I think it's just always the right thing is to go to a physician if possible, because of safety and sourcing. And I just couldn't imagine getting something from my gym trainer. That just seems a little odd, but people do this. I'm just telling you. So.
Well, we've just about run out of time. But if you could go back and speak to yourself when you first were training to be a forensic scientist of what the future was going to hold for you, what would you have said?
I would tell myself, do not be closed-minded, be open. You don't have all the answers. And the people that tell you they have all the answers, they don't have all the answers either. I would tell you that be humble, because people that are naysayers about certain aspects of how you will practice or what you will think, they don't quite understand all the things that go into what you do, but also understand many people who didn't necessarily subscribe or believe in the type of medicine you're going to find yourself practicing will find themselves as your patients, or they will find themselves doing that type of medicine. And I see that. I just saw it an hour ago. I see it all the time. And those are times to celebrate, not denigrate. You don't tell those people, I remember when you didn't. I remember when you poo-pooed on this. I don't remember. Absolutely not. I believe wholeheartedly doctors are inherently good people. The system, especially here in America, is somewhat upside down in how the money flows and how the patient is treated. And it's really what I call the medical machine. So I would tell myself back then, I would tell my future self, understand that you're going to have to go through all of this and learn all this and be trained and take tests and get it and achieve a certain standard on being able to be competent to do medicine in America. But also understand that all the things you're taught in the books and in residency doesn't necessarily align with pathology you see in your clinic every day. And if I told myself that back then, I would have gotten here even faster. So.
Well, thank you very much for having joined us today. It's been amazing. We'll have to have you back again and educate us further. So we look forward to that. And once again, thank you very much for joining our advisory board. Really appreciate it.
Thank you, Linda, very much. I appreciate the opportunity.
Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.